Today we're going to speak about key methods of analyzing ED operations. This talk is geared towards fellows in emergency medicine administration and operations. So the objective of this brief talk is to discuss the basics of ED operations, queuing in the emergency department, and the importance of variability and human factors. Emergency department flow can be represented as a series of processes in parallel and series. Processes that are in series need to be completed one at a time before you can get to the next one, versus processes that run in parallel can run at the same time or at different stages of speed in the process. When you have processes that run in series and you have a process that slows down, points before that will back up. Triage, ED workup, and the admission or discharge process are the three major buckets of ED flow. It's the period of time before the doctor gets to the patient, the period of contact time between the doctor sees the patient to the doctor makes a decision, and the period of time between the decision and the patient leaving the emergency department. We always have to contend with limited resources and with variable inputs, and we'll talk a little bit more about this in a minute. We will use triage as representative of ED processes throughout. We will do this because it is part of ED process everywhere. It tends to have a discrete number of steps, and it is short enough and reproducible enough for discussion. So in general, with regards to ED operations, you have to ask yourself, what can you control? You have variable levels of control over your resources, be it staff, equipment, and beds. You have some variable control over where and when you place your resources. You also have a fair amount of control over how you perform discrete tasks. You have limited to no control over your inpatient volume and acuity, and this is why ED operations tends to be much more difficult than operations in other parts of the hospital. With regards to process improvement, there are a number of things that you should pay attention to. Decreasing process variability is the bulk of what you do in emergency department operations. If you can do things in a systematic way, they become more predictable. And once they're more predictable, then you can work on making that process better. A lot of making the process better in emergency medicine means making the process time shorter. If you make the process time shorter, it means that with the same resources, you can process more patients, which means that overall, you are increasing the amount of resources you have or decreasing the amount of resources that it takes to do something. It's essentially the same thing. Another thing that you will do a lot is trying to match resources to demand. This really involves moving around pieces that you have available in the emergency department to fit your flow. A third thing that you can do, but it's much harder, is try to shape demand. Can you reduce return visits? Can you create a fast track area where you can move some of your demand to? Can you set up appointments for some of the things that you have to do and try to shape the demand curve to better fit your resources? If you're doing a fellowship already, I am sure you have heard about Lean and Six Sigma. These are two of the big systems designed for process improvement. The most important thing to remember about this is that they assume that you have a process in place. If you don't have a reproducible process in place, then Lean and Six Sigma will be of a lot less help. Once you have a reproducible process, these are good for trying to improve the process itself by eliminating steps that do not add value or improving the steps that do add value to the process. In general, everybody wants fast, good, and cheap. You will be asked to do all three at once. It is unlikely that you will be able to do more than 2 out of 3 at the same time. You just have to remember that everything is a compromise between the three, and your job is to be explicit about trade-offs that must happen for any particular process. You must determine what is the most important thing and what things you will have to sacrifice given the resources available to you. So how can we make things better? The easiest way and the least available way is to throw money at the problem. If you have tons of money, then you can just add more resources and you probably will improve your processes overall. This is unlikely to be a choice available to you. Most of the time, when you are asking for more resources, administrators will ask you to provide a return on investment. So you will have to provide them with clear reasoning as to why those extra resources are needed. Space is a very difficult resource. It is hard to increase that resource, but there are ways to better utilize space to increase its utility. Capacity demand matching is a very important thing of what you will do, as your resources may be limited, but the time when you place those resources may not be. Some of what you're trying to do is reduce idle resources and shift them to times where the resources are in greater need. And then, of course, you will always be trying to make individual processes better, which allows you to reduce costs, potentially add more resources. And a lot of this has to do with standardization. So triage, which is the first Q, and I hope you have heard about queuing theory before today. So if you have a triage nurse and they can process a patient every 6 minutes, how many can you process in an hour? So the answer that most people would give you is 10. You work in emergency medicine and you know that this is not true. Why is this not true? So this is not true because inter-arrival time is variable, triage time is variable, and variability will lead to both waiting and unused resources. The more variability you have, the more waiting you will have, and more unused resources you will have. So in our triage example, you will not get anywhere near those 10 patients an hour before you start accumulating wait times. There are 3 major sources of variability for this example. The time it takes to perform the triage. This is amenable to reduce variability if you have a good process in place. The timing of patients arriving during any particular hour. You have little to zero control over this. The arrivals per hour of the day. Again, you have limited control over this, so you tend to shape your resource curve to the demand curve. So remember, a queue will either increase by 1, meaning there's a new patient waiting to get triaged, decrease by 1, meaning you have finished triaging a patient. The standard 3 queuing inputs for queuing language are your arrival rate, so how many patients per hour are coming to get triage, your service rate, how many patients per hour can your triage nurse process, and the number of servers, meaning how many triage nurses do you have available for triage. In our example, once you have an arrival rate of 8 patients an hour, with only 1 triage nurse, your average wait time per patient will stabilize at somewhere around 24 minutes per patient. This is at a triage utilization of 80%. That 80% number is very valuable because once you exceed that 80% utilization rate, your waiting times will increase very quickly. You also have to remember that there is variability in the spread of some of your bell curves. So for most purposes, we tend to regard emergency department data as being bell-shaped, even though it's not. Most emergency department data is actually skewed to the right because time 0 is a fixed time, but waiting times can extend close to infinity. But the variability in terms of arrivals and everything else can vary significantly from institution to institution, with smaller emergency departments being much more likely to have a broader variability than larger places because smaller systems are more volatile than larger systems. So the way I would recommend you start thinking about these things is as a failure rate. So how many patients can you actually handle? And how often does your system break down? If you staff to the average to 50%, then by definition, you will fail about half the time. If that's an acceptable failure rate, then that's fine. If it is not, then you need to have some real discussions about what your acceptable failure rate is. And remember, never failing is impossible because it requires infinite money and resources. So in general, emergency department flow can be represented as a series of processes in parallel series, how we said. And again, the 3 buckets, the times before the doctor sees the patient, the workup time, and the time after the decision. And recognizing what your actual resources that limit your flow and your bottlenecks are is very important so you can best utilize your resources. For example, point of care creatinines for IV contrast CTs. If your CT utilization is low enough, having a point-of-care creatinine that gives you an immediate creatinine may be useful in increasing the speed through the scanner. If the scanner is the rate-limiting step, then getting a creatinine back immediately is not going to add any actual improvement to the flow through the CT scanner. We will shift quickly to another thing that you will be doing a lot, which is staffing. And the way that most systems staff is they try to figure out how many patients per hour a provider can see. They take their average volume curve for the day and try to stack providers in terms of patients per hour to try to fit the curve as best as they can. The problem is that prior curve is an average curve over a long period of time. Your single day view will look very different, so you will have some imbalances that are very difficult to predict. The other thing to consider is that those patients per hour is not a static number throughout a shift. Physicians, residents, PAs, we all see patients early in the shift at a much higher rate than at the end of the shift. And accounting for this is very important for constructing intelligent systems that take into account the appropriate staffing. This is a better way to take into account this. So the blue bar is what most people use when they try to do staffing. If you utilize the red line, the stair step, it actually gives you a better idea of how many patients in any particular hour a provider is seeing. The area under the curve for these two is exactly the same, but the way those new patients per hour are processed are very different, and this has some significant downstream effects. For example, if you look at the top graph, it utilizes a static patients per hour model to try to fit the volume curve. If you look at the bottom one, it's the same total patients per hour, but it uses a staircase model. And as you can see, there are big peaks of imbalance throughout the day, where some at times there is more resources than are needed, and there's some chunks of time where there's certainly a lot less resources than are needed. So when you have that information, you may redistribute your shifts to better fit the curve in a way that makes sense. A few other things to take into account. There is this concept called social loafing, which is a term used to describe human behavior when less effort is done when there are others available to do work. The best example for this in emergency medicine is when there are multiple providers waiting to see a patient, and the next patient that comes up to be seen is a vaginal bleeder. The natural reaction is everybody will wait a variable amount of time in the hopes that somebody else will see the patient. This happens with every sort of work when many people are serving the same line, and it is just part of human nature. But if you do not account for it, then you will build systems that in theory are a lot more efficient than they are in practice. There is always batching behavior, which we all know, and there's end of shift behavior. So this is a good example of batching. The red line is what you would expect patients' dispositions per hour to be, given standard rates of time to disposition. The blue line is what actually happens, which means that at the beginning of your shift, you prioritize seeing new patients, and at the end of your shift, you prioritize dispositioning patients. This is just part of human behavior. Trying to change it is very difficult. Taking it into account will be very helpful towards making more intelligent staffing decisions. So how should you look at things? Remember, many ED processes are interlocked. You must determine whether the process takes into account more people skills or machines. People will behave in ways that are different than machines, right? If the process is mostly a lab process, for example, then that will be a very reproducible process throughout every hour of the day, versus if you have a people process, that process may change depending on the time of their shift. The length and complexity of the process is also important, and can you break these processes up into smaller processes that you have better control and better reproducibility. Remember, what do you have the ability to influence, and always ask the question, how often can you fail? In summary, we're to utilize medians, not means, because most of our data is not normally distributed. Utilize interquartile ranges when possible to give you a better idea of the spread of your data, because this again relates to how often are you allowed to fail, right? How often is it okay to exceed a certain time metric for something? Utilize screen theory concepts. Figure out what your red line is. That is how you decide, how many resources you need to put in to try to stay on one side of that line. Remember, humans and machines behave differently. And always remember that resource availability may force you to make suboptimal decisions, but at least you can make these decisions consciously as opposed to being sad that something's not working the way you meant it to. Good luck with your career.